Hi, I'm Matt Reed and I'm an emergency medicine academic from Edinburgh and I've a special interest in syncope. Today I'm going to speak to you about management of syncope in the ED and the risk stratification methods. Here are my disclosures. The Aspired study, which I will mention, is a non-commercial study independently funded from a research grant from the BHF. I was also a member of the ESC task force and am supported by an NHS Research Scotland Career Researcher Clinician Award. My objectives of this talk are to categorise the burden of syncope in the ED and to discuss why ED physicians sometimes struggle with managing it. I will suggest my own personal approach and also talk about the approach used in the recent ESC guidelines. I will touch on why decision rules are problematic and put forward an alternative ED approach for the future focused on diagnosis from the ED. To put syncope in context, it is responsible for around 400,000 of the almost 30 million presentations to UK EDs and falls just outside the top 10 commonest presentations at the Royal Infirmary of Edinburgh Emergency Department. Median length of stay is 1 day. About half of patients stay overnight, but the remainder stay for much longer. Half are admitted, with almost 3/4 being admitted directly to general and acute medicine. So why do we find these patients so difficult to assess and manage in the ED? Well, firstly, there are some rare causes of syncope which most emergency physicians will be unlikely to see in their practicing lifetime. We sometimes have the opportunity to pick up and prevent these unfortunate events that these rare causes can lead to, such as this, of course, the case of Fabrice Maramba, who had hypertrophic cardiomyopathy, the commonest cause of congenital cardiac disease. This ECG shows the classical Hocum pattern with voltage criteria for left ventricular hypertrophy and deep narrow Q waves in the lateral leads, 1 AVL and V5 to 6. Another cause we need to look out for is the long QT syndrome. One famous case is of Olympic swimmer Dana Vollmer, who won a gold medal at the London Olympic Games in 2012. At the age of 15, Dana was diagnosed with long QT syndrome after experiencing a dizzy spell whilst in training, and was luckily diagnosed. Another topical, well-publicised serious cause of syncope, this one of former England cricketer James Taylor, who was diagnosed with ARVC, arrhythmogenic right ventricular cardiomyopathy, after an episode of VT. His ECG shows T-wave inversion in V1 to V3, which is found in about 85% of patients, and the more specific finding of an epsilon wave, which is seen in around 30% of patients. The final ECG we cannot miss as an emergency physician is Brugada, here showing the downward sloping ST depression in V1 and V2 with T-wave inversion, for which the definitive treatment is an implantable cardiodefibrillator. Undiagnosed Brugada syndrome has been estimated to have a mortality of 10% per year. Some patients with poor cerebral circulation may have slight confusion or not be quite right, or have a lactic acidosis that's sustained after a vasovagal syncope. However, most patients are back to normal in the ED, irrespective of the underlying cause. Unlike this poor television weather presenter, syncope is commonly unwitnessed. The patient has little recollection of events, and therefore diagnosis can be very difficult in the ED. Attempts to try and risk stratify patients in the emergency department have led to the derivation of some clinical decision rules to decide who to admit and who to discharge from the ED, with the San Francisco syncope rule being the most well known. Unfortunately, many are not validated or not sufficiently accurate for clinical use. None have been widely adopted, none outperform emergency physicians, and most lead to increased admissions. However, there is a new kid on the block. The most recent of these, the Canadian Syncope Risk Score, has been derived and externally validated in almost 6,000 patients, and is probably the most robust of all the clinical decision rules. The authors advocate a threshold admission score of 0, such that those with a score of -1 and below are discharged from the ED. There is no doubt that an increasing score predicts outcome, and the admission rate would only be 44% at an admission score of 0. But the 9 serious outcomes in the external validation study equated to a sensitivity of 93%, which is probably not acceptable to ED clinicians. There were, however, no deaths or ventricular arrhythmias in those with a score of 0 or below. Using a score for admission of -1, i.e. those with a score of -2 and below a discharge, gives a much better sensitivity of almost 98%, but unfortunately leads to admitting 56% of patients, which is very similar to our current practice. Now, there is some reassurance for emergency physicians here. Previous studies in the 90s reported a 30% one-year mortality for patients thought to have a cardiac cause of syncope, which really highlighted syncope as a high-risk ED condition. However, as part of the ESC guidelines, a look at more than 10,000 patients from 13 studies showed that a 1-month mortality rate of actually less than 1%. And although 10% of patients have a non-fatal severe outcome, 2/3 of these outcomes are apparent and diagnosed in the ED. So now syncope studies and research studies are more focused on only investigating patients or enrolling patients whose diagnosis is not known in the ED. So I've got this approach to syncope. It's a 3-part approach, and first of all I ask, is it syncope? Transient loss of consciousness, or TLOC, refers to undifferentiated neurological seizure and syncope. Syncope is TLOC due to cerebral hypoperfusion. There are many potential causes of the episode, such as presyncope or lightheadedness, vertigo, mechanical fall, or true collapse query calls, which is when a patient cannot support their body weight due to frailty and intracurrent illness. Neurological seizure is more likely if a patient does not recover fully within a few minutes, and just remember that anoxic seizure activity is not uncommon in syncope and can mimic a neurological seizure, but is normally much more short-lived. In neurological seizure, movements can last minutes or more, and in syncope, the movements tend to last seconds. In syncope, the movements occur after the onset of unconsciousness and after the fall, whereas in neurological seizure, these occur before the onset of unconsciousness and before the fall. Some people suggest that a tongue bite occurs more often in neurological seizure and tends to be on the side of the tongue, whereas it's on the tip in syncope. However, this is not as reliable. So my second question I ask myself is there an obvious diagnosis? Once we have established an underlying diagnosis, we then follow the management of that particular condition. So for example, here, subarachnoid hemorrhage, aortic dissection, ruptured abdominal aortic aneurysm, or an ectopic pregnancy. Finally, I ask myself, is there a high risk of cardiac cause with this patient? Is the patient at risk of a cardiac cause? The causes that we're interested here are arrhythmia and structural cardiac causes. The more benign causes are reflex syncope and orthostatic hypertension. And if we can establish one of these more benign causes, then the management of the patient will not necessarily involve admission to hospital or intensive follow-up, unless obviously they have coexisting comorbidities or trauma related to the syncope episode. Less reassuring for emergency physicians is this sub-study of the PATCH-ED study, which we did, which involved putting an ambulatory ECG monitor on ED syncope patients and asking emergency physicians for their assessment about whether the diagnosis was likely cardiac. Whilst there's a trend for lower scores having less major adverse cardiac events, it is clearly not always possible in the ED to predict a cardiac cause of syncope. There are many patients who have a 10 out of 10 likelihood, one patient who had non-cardiac cause, and there are patients obviously at the other end with 0 and 1 likelihood of underlying cardiac syncope who ended up having a cardiac syncope cause. My top 5 important aspects of ED syncope management are: number 1, history; number 2, history, number 3, history, number 4, ECG, and number 5, lying standing blood pressures. And to emphasise even further the importance of history, this is a case report of a 25-year-old male who had a transient loss of consciousness during a tandem skydive in New Zealand. On the face of it, pretty concerning. Any takers for which category of syncope this might fall into? The author began to experience paresthesia in his arms and legs and then felt lightheaded before shortly becoming unconscious. So yes, this is a classic history for venous pooling and reduced venous return secondary to the leg straps. Luckily, it was tandem and not solo, so I lived to tell the tale, and here is me 15 minutes later with much less grey hair, neurologically intact, although maybe some will disagree, and a very impressive Dressage sign. This demonstrates the importance of a clear history which gives us the diagnosis here, and also of being aware of occupation, which might be important when thinking about driving advice. I'm not suggesting for 1 minute it should be mandatory to experience a condition you have an academic interest in or to feature in a case report on it, thanks to my colleagues who were there at the time. Syncope during exercise is important, and again, history is king. A girl collapsing whilst running for the ball playing hockey is a slam dunk for cardiac syncope. A girl who felt unwell at half-time went to sit down for 5 to 10 minutes before feeling more unwell, more lightheaded and nauseated, and who then collapsed, hasn't got cardiac syncope. Again, as I said, history is key. The length of pre-warning is also important. In reflex and vagal syncope, it is typically longer than with cardiac syncope, for which there is often no warning. We must always ask about family history. The first documented case of long QT syndrome was described in 1856 when a deaf girl died after her teacher yelled at her. Soon after being notified, the girl's parents reported that her older brother, also deaf, had previously died after a terrible fright. And sometimes unexplained deaths in the family is the only way we can diagnose these congenital syncopal conditions. In the ED, always make sure you do a lying and standing blood pressure with blood pressure sitting or lying. Get the patient up and take a early and delayed reading at 1 and 3 minutes and a 12-lead ECG. And always do the lying standing blood pressures yourself rather than asking the nursing staff to do it, so you get a feeling for exactly how symptomatic the patient was at 1 and 3 minutes. And also you can see how that corresponds with either an increase in heart rate or a drop in blood pressure. Blood tests, x-rays, rarely useful in the ED. Potentially a haemoglobin if you're using the San Francisco rule, and can obviously be associated with an episode of becoming faint or unwell, but otherwise there's not really very much else you're going to pick up with investigations in the ED. Troponin, often get asked here about whether I should do troponin to rule out acute coronary syndrome. The evidence is sparse here, but I would suggest that most of it points to the fact that if the patient has chest pain, we should do a troponin. If the patient has ECG signs of acute coronary syndrome, again, we should do an ECG. But if they have neither, we shouldn't really be doing a troponin to pick up an acute coronary syndrome, as any troponin rise is likely to be due to a type 2 myocardial injury, MI, secondary to arrhythmia or an episode of postural hypertension, and not diagnostically useful in terms of STEMI or NSTEMI. The ESC guidelines, which I touched on at the beginning, were published a couple of years ago and are the first ones that have involved emergency medicine involvement. I would thoroughly recommend having a look at them. There's a table within them that gives some excellent low-risk features and high-risk features associated with the ECG, with passing history, physical examination and the syncopal event, and allows us to better stratify the person into a low risk and a high risk. And once you have followed the guideline, you can follow this chart, which allows you to decide if someone has any high risk features They require admission to hospital or an assessment in a clinical or syncope decision unit if that's available, and that patients who are low risk can probably be discharged from the ED. It's also worth considering a care and referral pathway along with advice sheets for patients with vagal and postural syncope, which are available in the ESC guidelines and you can adapt for your own emergency department. However, my thinking here is that if the patient is high risk and we're worried about an arrhythmia, then in the ED we want to be doing better for them than trying to identify a potential high risk patient or risk stratify them to potential, although that is the best option available to us at the moment. But I think we need to be better at diagnosing these patients, both in the ED and from the ED, the ones that we're worried of high risk causes such as structural and arrhythmia causes. And so what's been holding us back? Well, unfortunately, up to now, the technology hasn't really developed much further than when Norman Holter started work on ambulatory ECG monitoring in the late 1940s. You can see from the photo here that his device wasn't very portable, with a key component of it being a Second World War radio pack. However, the technology in current use is not that much better, with the current versions of the Holter monitor that was developed during the 50s and released in the early 60s, only able to record for 24 hours, and as you can see, definitely not compatible with daily life such as showering, running, exercising, etc. At last though, the tech has caught up, and there are now some ambulatory ECG monitors on the market that can continuously record a single lead ECG for up to 14 days and can be worn while showering and living our usual lives. Our patched ED study took 86 ED patients with unexplained syncope and fitted them with an ambulatory patch ECG recorder. Our standard care group was a historical cohort of 603 patients with unexplained syncope and no obvious diagnosis. We had 76 ECG patches returned, having been worn for 14 days. 56 of these patches recorded a diagnostic finding, that is, an ECG recorded during a syncopal episode. 34 of these showed normal sinus rhythm or ectopic beats during the symptoms, meaning that the patient could be discharged from the cardiac clinic with a non-cardiac diagnosis likely, but 9 recorded a serious arrhythmia during symptoms. This study demonstrated that patients whose syncope is unexplained do have a burden of disease that is sufficient enough to warrant investigation. These significant arrhythmias occurred right up to 14 days. Our patch ED findings have been supported by the result of the Canadian syncope rule derivation and validation studies that also looked at the timing of cardiac arrhythmias. The Canadian group proposed 2-hour monitoring in the ED for low-risk patients and 6-hour monitoring in an observational unit, followed by 2 weeks of ambulatory monitoring with review in an ambulatory medicine setting for patients who are medium and high risk on the Canadian syncope score. Using this strategy, they detected 50% of arrhythmic outcomes within 6 hours and 92% of arrhythmic outcomes within 15 days, therefore supporting a 2-week outpatient monitoring strategy for selected medium risk and for all high-risk patients. And this leads us to the Aspired study. We received a grant from the BHF last year to fund a UK open-label randomised controlled trial of immediate 14-day monitoring versus standard monitoring in over 2,000 patients presenting acutely with unexplained syncope to UK EDs and acute medicine units to see whether this early prolonged approach of monitoring reduces syncopal events over the next 2 years. Hopefully when I stand up in front of you in 4 years' time, we'll have the answer as to whether an early diagnostic approach using novel ambulatory technology is the correct one. Your hospital may already be involved, but if not, get in contact if you're interested in taking part. Don't forget counselling patients about driving before they leave the ED. This will be touched on a bit later on during the programme. RChem has an SOP based on the DVLA guidelines, which you can also download for your department. We've recently set up a rapid assessment syncope clinic or RASCL clinic in Edinburgh based on some of the excellent work that Laura Mitchell has successfully embedded into syncope management in Glasgow. The Glasgow Rascal Clinic has successfully reduced admission of low-risk patients. It provides appropriate follow-up for intermediate-risk patients and reduces length of stay for those requiring admission to hospital. It's vital that specialist clinics such as this are run by Syncope experts who can pick out the nuances of the patient's story and not protocol-driven like most ambulatory care models. We've looked at the results of the first year of our clinic and have shown that whilst we haven't reduced admissions, we have given better care to patients and we have better signposted them to the right specialties, producing more diagnoses and better patient satisfaction. So to summarise, syncope is commonly thought to be difficult to manage by emergency physicians and acute medics. I suggest a systematic approach, thinking first of all, is this syncope? Secondly, is there an obvious underlying cause? And if so, go down the management pathway of the underlying cause. If we don't have an underlying diagnosis in the ED, then risk stratify the patient to determine whether they're at high risk of a cardiac cause using either the ESC guidelines or your own local department guidelines based on features of high-risk cardiac syncope. However, I hope in the future that we'll have a better way of managing these patients, focus more on diagnosis, and that we'll be able to do more for them from the ED, such as early ambulatory ECG monitoring. Thank you very much for listening.